Today our talk it will be about tricuspid valve repair versus replacement in left-sided valve dysfunction. So we'll start with the case scenario. We have a 49-year-old female who has long-standing history of rheumatic heart disease with mitral stenosis and chronic atrial fibrillation. She underwent balloon valvotomy 1 year ago prior to her presentation to us. Currently, when she came to us, she was asymptomatic with severe MS and moderate MR, and shortness of breath NEHA class 2 to 3, and moderate TR with RV dysfunction, and the pulmonary pressure estimated to be 50 to 60. So here you can appreciate in this long axis parasternal view, very dilated left atrium, the pathology on the mitral valve, dooming and thickening of anterior leaflet, restricted posterior, and you can notice here mild to moderate RV dysfunction. Sorry. In apical four-chamber view, you can notice mild to moderate TR, dilated RA as well. The anatomy of tricuspid valve is a complex anatomy. It consists of 3 leaflets, anterior, posterior, and septal leaflet, as well as 2 papillary muscles attached to it, RV and RA. And the most important thing is to pay attention about surrounding structure around the valve, mainly the conduction system, which lie on triangle of Koch and aortic valve, and also you need to be aware of right coronary artery, which run at this area. Now we'll move about to talk about pathophysiology, causes, and diagnosis of TR. TR either due to primary, which is organic, due to different causes, congenital, iatrogenic, like lead, endometrial fibrosis, or myxomatous, traumatic, infective endocarditis, or the primary, which is functional, most commonly due to left-sided valve disease, mainly MR, AS, MS, and that will lead to increase in air pressure, increase in air side, and both of those will lead, eventually will affect the right-sided and will lead to tricuspid valve annular dilatation, also because of the effect of the lesion on the left side that can lead to pulmonary hypertension or RV myocardial dysfunction, RV dilatation. Endpoint will be the tricuspid valve tethering and annular dilatation and TR. Dreyfus write an review article about functional TR after establishing the diagnosis, either left-sided heart disease or atrial fibrillation that will lead to RV remodeling, altered RV function. You will have functional TR. When you assess it, you need to assess tricuspid regurg plus annular dilatation plus the cohabitation of the leaflet. Then in diagnosis and treatment, you have 3 stages, either severe or non-mild with no annular dilatation, good cohabitation, you just continue medical management. However, if you have annular diameter more than 40 or cohabitation mode abnormal, at that time, you need to address the tricuspid valve on the same time. And of course, with the severe, you need to address it on the same time. Regarding current guideline for left-sided, if it is mild or moderate, from American Heart Association, at the time of left-side valve surgery, if you have dilated annulus, you need 2A to repair pulmonary hypertension without dilatation, which is a risk factor, 2B to repair. For severe one, asymptomatic functional, class 1, asymptomatic at the same time of left-sided, you will repair it. Same in the European guideline, in the left-sided valve dysfunction, you need to address the tricuspid valve. And if you have a recent sign, this is a difference between them, of right heart failure, at that time, you need also to address the tricuspid valve on the same time of the surgery. Here it's class 1 for severe, class 2A for dilated annulus 40 or index 21. And if you have right-sided, right-sided failure, without annular dilatation to address on the same time. Dreyfus also wrote this article: intraoperatively, you need to intervene if you have the annular diameter from anterior septal commissure to the anterior posterior commissure 70 millimeter, which correspond to 40 when you measure it in echo edge to edge measurement. So at that time, intra-op, you need to intervene. If you can notice, this is from analysis of thoracic surgery, the trend of a number of tricuspid valve procedure, it's increasing nowadays due to more awareness and the impact of TR on the long term. And if you can notice, it's almost from 2006 and now 2016, it's double the numbers being performed on the tricuspid valve, either concomitant or isolated. So what's the surgical approach and technique for tricuspid valve disease, either repair or replacement? In repair, the common one is, and common being used, is tricuspid valve annuloplasty, reduction or to do reduction, as well as this is using other De Vega technique, and you can use caliper to know exactly how much you want to decrease the annular size. Also, we have bicuspidization technique. Moreover, we have a Clover technique, which was introduced by Alvari. Moreover, you can also use a pericardial patch. This is especially in cases of infective endocarditis. Then lastly is tricuspid valve replacement. An article was published on 2010 surgical analysis of 277 different repair technique, found that the less technique lead to TR progression is a rigid prosthetic annuloplasty with a 12 years at a 5-year, followed by flexible ring, 16 bicuspidization, at least De Vega technique. You can see the trend here. They use the rigid ring, Carpenter Edward rings, which is rigid ring, and the latest one, it's De Vega technique. Moreover, in 2020, from Annals of Thoracic Surgery, analysis of 650 patients to examine the outcome after tricuspid valve repair with ring versus suture bicuspidization annuloplasty, found superiority of the ring over suture bicuspidization for tricuspid valve repair appears to be evident and better in terms of event-free survival and freedom from valve insufficiency and also reoperation. Yes. Now we will move to talk about tricuspid regurg and mitral and aortic valve surgery. The secondary TR among patients with mitral valve pathology need to be addressed at the time of surgery according to the degree of TR. Even mild TR can progress and affect morbidity and mortality in long term, especially with RV and LV dysfunction, which is a risk factor. The choice of tricuspid valve intervention depends on feasibility of repair first versus replacement. Still, replacement is still a valid option when tricuspid valve has hostile pathology or patient is in critical condition. And a review article found that unaddressed TR after mitral valve surgery can progress, and the risk factor prophylactic tricuspid annuloplasty. This is a small RCT published in 2012 and showed that addressing the tricuspid on the same time, especially in patients with rheumatic and functional pathology, will benefit the patient and decrease morbidity and mortality, and also improve the RV function after that. Then a review article was examining the tricuspid regurg that was unaddressed after successful mitral valve surgery, and found that risk factor that can lead to progression of TR: right chamber dilatation, dysfunction, high pulmonary artery pressure, longer time from onset of mitral valve disease, especially in rheumatic patient, history of rheumatic, female, larger in A size, atrial fibrillation, and prosthetic valve dysfunction. An editorial was written by Patrick McCarthy in 2015, and he found that he was actually encouraging the Surgical Society to be more aggressive in treating functional TR with left-sided valve lesion, as that will improve morbidity and mortality in early and long term. Moreover, Robert Dion also he wrote an editorial and agreed with McCarthy, and he added that concomitant functional TR repair to do repair before irreversible annular dilatation more than 40 will help decreasing morbidity and mortality. Also, and actually, he had where do I stand now with my own practice, and any patient in gray zone area that they TR less than 2, but greater than 3.5 and less than 4, the diameter of dilatation of the TR. But he will address it in cases of atrial fibrillation, rheumatic heart disease, pulmonary hypertension, RV dysfunction, tricuspid valve leaflet cohabitation less than 3, dilated cardiomyopathy, and LV dysfunction. Tyron David also wrote, when is the tricuspid valve annuloplasty necessary during mitral valve surgery? And Dr. Tyron actually found that patient with rheumatic heart disease, they will benefit most from addressing aggressive approach with the tricuspid valve at the concomitant time of mitral valve, but with a maximatous mitral valve, not that much, and need from us to follow the data regarding that point, because central message from him that new functional TR after mitral valve surgery remain an unresolved problem. In Mayo Clinic in 2019, they did an analysis of 13,000 patients with a heart failure and reduced ejection fraction, and they found that majority of patients, 88%, they have TR, and that associate with the worse survival. Even with a mild TR, it will affect the survival, and it will be more pronounced with severe TR. However, they found that right ventricular dysfunction, not related, but pulmonary hypertension, it will affect right ventricular dysfunction is affecting more, but degree of pulmonary hypertension, they didn't find that to be associated in their study. Another study was published in 2020. They follow the outcome of guideline-directed concomitant annuloplasty for functional TR on the same time, and they found that addressing the TR actually will have excellent safety endpoint, and also freedom from moderate or worse tricuspid regurg with high with improvement in the RV function. A review article in 2020 also was published in Annals of Thoracic Surgery, found that repair of less than severe tricuspid regurg during left-sided valve surgery in their meta-analysis, and this is the study they included, combined with many small randomized control trial and observational study. They found that if you address the tricuspid, cardiomyopathy bypass time will be more when you do repair, of course, and early mortality no difference, but numerically favoring the repair. However, cardiovascular mortality is favoring repair, tricuspid valve regurg progression favoring doing repair, and all-cause mortality significantly favoring the repair. Also, another question was the impact of tricuspid regurg with and without repair during aortic valve replacement. In this article, analysis of those patients, they found that addressing tricuspid on the same time of AVR will reduce morbidity and mortality, and they examined 17,000 patients, and severity of TR found with those patients 41 mild, moderate 6%, and severe 1%. Interestingly, the rate of concomitant tricuspid valve surgery with a mild patient 0.1, moderate is only 2, and severe only 31%. However, in propensity match pair score, they found it will affect morbidity and mortality, and they recommend to address that in the same time of the AVR, because that will benefit the patient at the end. What about repair? Okay, what about repair versus replacement? Many data comparing both came from isolated TR. However, this study found that replacement actually is associated with more morbidity as well as permanent pacemaker insertion, and repair is better, of course. In this cohort study from Taiwan, they found that concomitant procedure repair was 1,974 and replacement 337, and their analysis found that all-cause mortality as well as composite outcome and cumulative readmission from any cause is favoring repair than replacement. And in the paper also that the RV remodeling is better with repair. What about tissue and mechanical valve? One of the review article published in 2014 in the Journal of Thoracic Cardiovascular Surgery that mechanical valve can be considered in select situation when anticoagulation is necessary and in the presence of good right ventricular function. This is very important. A big meta-analysis in the evidence-based paper topics, they found that mortality is the same between mechanical and tissue. Reoperation rate is the same. However, is due to mechanical thrombosis in mechanical valve. Thrombosis in mechanical valve and degeneration in bioprosthetic valve. And they found that 95% of patients with bioprosthesis still receive anticoagulation for any other reason. So now we'll back to our case. Our patient actually, she went to a MVR plus ATS30 plus tricuspid valve repair with 3D contour ring size 26. Patient, as I mentioned before, she has AFib and her TR was borderline. The annulus, it wasn't 40 for the guideline. So per guideline, she's 2B, but remember, she has AFib that wasn't addressed. There is mild to moderate RV dysfunction. I show it to you in the echocardiography. Patient actually discharged home postoperative day 7. However, initially her post-op echo was good, and we need to follow this patient to see the end result of that tricuspid valve repair. So in conclusion, tricuspid valve is not anymore the forgotten valve. Deep understanding of anatomy and pathophysiology of functional TR is important for future therapeutic solution. Adherence to our current guidelines need to be more emphasis in surgical community, as with current and ongoing research, the evidence of intervention on functional TR is clearly has its impact on morbidity and mortality, especially among certain subgroup of patients, the risk group that I mentioned. Tricuspid valve repair with remodeling rigid annuloplasty ring is the current best surgical approach according to the literature to address functional TR. However, replacement with bioprosthetic valve is also good option when the repair is not visible, and mechanical valve may be considered in certain circumstances. Remember, personally, I favor bioprosthetic because of that you can do valve on it, and also you can, if you want to do BiCath pacemaker, you can do it with a tissue valve bioprosthesis, but that with mechanical valve. So this is the two reasons I favor bioprosthesis, and also because the longevity for the tissue valve is better on the tricuspid position than mitral because of the pressure system there, not like the mitral. Sorry. This is my reference. Along with the reference, I put it on the lecture. Thank you very much. Floor is open for the question.
MashaAllah, 19 minutes. Thank you very much, Dr. Haitham, for this presentation.
Haitham.
Hello, Doctor.
You didn't mention an advantage of tissue valve tricuspid that you can make the re-replacement transcatheter.
Yes.
tissue valve.
Yes,
Is
valve
that
and
right?
valve. Yes.
valve. كم حالة valve and valve you saw?
For tricuspid, till now, none. I think in military hospitals, they do a lot of those cases. In our center, King Fahd, till now, I didn't saw any case.
نقدر نسأل أسئلة؟
طبعا دكتور.
Okay, Haitham, do you remember my question?
Yes.
So
okay,
how do you avoid?
So avoiding heart block in cases of replacement and repair. In repair, the design of annuloplasty ring actually is avoiding the septal leaflet. So we are away from the conduction system, and in replacement, when we cut the septal leaflet, we have to leave some remnant of the septal leaflet and to put the suture on the leaflet, not on the annulus. And the most important thing is at 7 to 9 o'clock. Imagine, so this is here is a 6 o'clock. So 7 to 9, this area need to be avoided when we are doing replacement. And the replacement, we will put our suture on the leaflet, not on the annulus.
Okay. Many times, by the way, when you do tissue valve, we do not resect the tricuspid valve leaflets. Okay, another question. A patient who is a drug abuser presented with endocarditis of both the mitral valve and the tricuspid valve. You take the patient after 5 days to surgery. He has positive culture for Pseudomonas, and you replace both valves. Patient is looking good. 1 week later, and he left the hospital after completing his course of antibiotic. What's his survival after 1 year?
I didn't, I need to check that exact survival, but what I recall, 70% maybe. I'm not sure, I need to check that, especially this is Pseudomonas, which is most, and double valve tricuspid. I need to check the percentage.
What's the mode of death in those patients?
Heart failure, reinfection, heart failure and reinfection.
Anybody else would like to comment from the other colleagues?
I think survival, it's less than 50%, and at 2 years will be survival less than 90%. Usually this group of patients die within 2 years, mainly by heart failure and reusing of the substance. They can use it before the surgery.
Okay, so it's not heart failure actually. It's either because of the drugs or because of a recurrence again into carditis, etc., or a stab wound to the heart or a stab wound somewhere because of their lifestyle. And it's about 90% in the first year actually, not 2 years. But anyway, of course, things may be different from one place to another. I want you to think more about the lifestyle of those patients when they come to you. Yes, you can cure the patient heart, but many times they succumb because of their way of living. But thank you.
Thank you very much. Also, I want to comment in the tricuspid valve replacement. It is very important. You know, in tissue valve, you have 3 struts. So the most important thing that the 2 struts will be one here and one here, and the third one will be here. If you put the valve other way around, you will compress the conduction system here. And the 2 struts must not be at the septal and anterior septal and posterior septal commissure. Otherwise, it's to be above. And also important things, especially with a large anterior leaflet, sometimes you can end up after replacement with RVOT obstruction. If you have this situation, when you come off pump, you need to go back if you have very long anterior leaflet to resect it, because as Dr. Farid mentioned, usually we preserve the leaflet, we don't cut it.
Haitham?
Yes.
So one of the core messages that I received, and you were encouraging the prophylactic tricuspid repair for patients who have mild secondary TR who didn't reach the indication for repair by the guidelines. صح?
Okay, so this is now, this exact question, it's evolving, and there is a lot of talk. Actually, currently there is an ongoing trial examining exactly this point. There is an ongoing trial in patient with mitral valve disease and underwent a repair or replacement, and to address the tricuspid valve when they have an indication, either 2A or 2B. I'm not speaking about severe TR, 2A or 2B, which is either you have tricuspid valve annular dilatation 40 or index 21, plus you don't reach this one, as Dion was mentioned in his editorial, but you have risk factor. For example, if you have patient rheumatic heart disease, his annulus was 38. By the way, our case here, annulus was 38. And
yes,
with atrial fibrillation and mild to moderate RV dysfunction. At that time, I will address the tricuspid valve. But if you have patient, let's say annulus is 38, but no AFib, newly diagnosed, young, newly diagnosed mitral valve stenosis, and no pulmonary hypertension, no atrial fibrillation, no RV dysfunction. At this point, even the annulus 35, 38, you don't address it, because the faith of those patients, they follow those patients, especially in rheumatic disease, they found that only 30% with the same scenario that I mentioned, they end up with later on TR. And why they are encouraging, why, and the message, why they are encouraging for aggressive approach for the TR, because the reoperation on patient had left-sided heart lesion replacement, then they will go for isolated redo TR. The operative mortality on this specific group from ranging in the literature from 8% to 33%, and depend on comorbidity and all that.
So this
is clear?
Compared, yes, clear. This is compared to doing the repair in the same setting, which has no significant increase in morbidity and mortality.
Actually, improve morbidity and mortality later on, and no increase in permanent pacemaker. This is in meta-analysis. You can find, when you go to the literature, you can find some series showing that there is increase, for example, of permanent pacemaker, but in the meta-analysis, they didn't prove that. Also, there is some controversy that the RV, it will not have that impact, but the meta-analysis of collective data showing improve in the RV function and improve remodeling. I'll just give you exactly what's in the literature. So how you interrupt that, it's depend on, you need to look to all the picture. So if patient really have some mild to moderate RV dysfunction, he will benefit.
اللي هي risk factors. طيب, is it safe to summarize it this way? If I have a patient going for left-sided procedure with mild TR who didn't reach the indication, يعني خلينا نقول borderline patient with risk factors, it's better to prophylactically address the TR. Without risk factors, we can leave it alone.
Without risk factor, yes, you can, yes.
Borderline with risk factors, we can do the
repair. But what is your definition of borderline?
Borderline يعني 38 annulus 20 index, يعني باقي شوي يوصل للانديكيشن بس ما وصلها لسه. بس عند other risk factors اللي تكلمت عنها.
Without RV dysfunction, without atrial fibrillation. Remember, nowadays the atrial fibrillation is what they call the new baby that can cause unproven atrial fibrillation. That can lead to functional TR. So any patient with atrial fibrillation, that patient, you need to address tricuspid. You need to address also the atrial fibrillation on the same sitting. And this is different talk about atrial fibrillation, because not all surgeons, they will address atrial fibrillation, especially if you have dilated left atrium. However, evidence now showing even with dilated left atrium more than 60, the role of atrial fibrillation is there, and you can do it, and patient will benefit from it. However, the failure rate is higher, but when you do it and you do with it,
you might succeed.
No, you do it and you do with it also left atrial reduction surgery, the patient will benefit from it. There is a good percentage of patients they will benefit from it. I sent the literature about that in the group for details. And also, when you close the left atrial appendage, we have a proof evidence that closing left atrial appendage will decrease the risk of stroke by 50%.
Yeah, Haitham, I have an objection to what you're saying. You'll be graduating very soon, hopefully, and you'll be in practice. And many times you'll be facing questions and reading articles that come with bright idea, but they don't mention, or they have not mentioned, all the bad experiences they can result in. My advice to you is that first, and in Murtada, you have to hear this, if somebody asks you, or in the exam, or in real practice when you are just starting your practice, I think you should stick to the guidelines. Do not go after recent articles that have mentioned this or mentioned that. Many times we have seen, in my lifetime, I have seen practices that have changed dramatically, 180 degrees. They come with an idea, everybody goes that on the bandwagon, and then after this, they change, somebody object, and they change, and it becomes very, very bad. And mainly because as people see the complication of that procedure or that medication or whatever, or that even strategy, technique in the ICU, etc. So be careful. The best thing, I think the best strategy for you, especially in the first maybe 5 years of your practice or career, stick to the guidelines. If you want to go beyond that, after explaining this is the guideline and this is probably what I would stick to, this article have mentioned this and this and this, you can mention it, but you have to be able to defend the ideas there, and you have to be really good. You may be facing somebody who's very critical about الموضة يسموها الموضة anyway. So you have to be careful. I think if you stick to the guidelines and always ask for help from your senior consultants or your senior colleagues that around you. Sometimes wisdom come from a long experience. Some of it is bad experience, but at least it's an experience that you can learn from. معلش آسف يا
No, totally agree.
Yes.
Totally agree. يعني in the tricuspid, the recommendation 2A or 2B.
طيب معلش هيثم last questions بس هذه يعني this information I wanted to know يعني زمان. الآن لو the patient has an annulus of let's say 38, okay, with a mild TR, and intra-op you measured the distance between the commissure, the septo-anterior to posterior commissure, and it was, let's say, 8. What would you do for this patient? You will address the TR or not? يعني مو أنا أسأل يعني what do you think يعني how should we handle this patient?
What is the scenario? Because this 70 mm in the guideline, you will find that they put Dreyfus article that published in 2005 about intraoperative 77 centimeters, and they mentioned that it is corresponding to 40 hinge to hinge in the echocardiography. And that mean, if it is A, that mean we miss, or there is a wrong calculation when we do it on the echo, because 70, it's supposed to correspond to 40 hinge-to-hinge point measurement. So you have class 2A to intervene.
Yeah, I think so. And the echo measurement might differ greatly with the loading conditions of the patient. But intraoperative, I think it's more accurate to measure the dilatation of the annulus. Is that
Of
correct,
course,
Dr. Farid?
yeah.
تفضل.
No, you ask Dr. Farid.
Okay.
Hey.
So both techniques do have their pitfalls. Even the direct measurement, it can have its own pitfall. You may be stretching too much, or maybe under stretching the annulus, so the measurement may not be that accurate. So your statement that surgical measurement is more accurate may not be true. Some of the experts of echo can maybe give you a better reading than what you look at it and try to measure it personally. Yes, volume status of the patient may be significant, but also flaccid status during surgery is can give you also some pitfall in measurement. So each technique has its own measurement issues. I would say the one that I'm sure about personally, when we used to use the Vega, for example, when we put that plug into the tricuspid valve and we tighten the suture on top of it, that may be the most accurate one, because then you have to use the suture. Now that suture does not last long. We have found quite a bit of percentage, 20–30% of the patients will have that suture rip off and become like a string across the, so they call it guitar string, across the tricuspid valve. So it's not, all of these techniques do have their own problems, and you just have to be aware of the potentials. The fact that Haitham mentioned earlier is after whatever repair you do and you use a ring, a rigid ring, your chances of having recurrence is less. It's not totally, absolutely zero, no. There's still a recurrence rate, but it's much less with the rigid ring compared to any other repair. Thank you.